from as with FEHBP?
No, I don't believe that they have the same program that we do.
Well,
No,
and that's that. I'm sure they don't. But I'm saying
they're limited.
They buy as a single customer. I'm asking that for those who subscribe, is there one plan and only one plan, or for DOD and for VA?
Well, I think the DOD and the VA have different approaches to their prescription drugs than what we're talking about for the FEHBP.
Mr. Chairman, I realize my time is up, but I do need to know.
Yeah,
I do need to know whether
give you another 2 minutes.
Thank you. I do need to know if veterans, if the largest part of the bureaucracy, the DOD, maybe they are so different that they really are apples and oranges. If so, I'd like you to explain.
Well, the DOD and the VA, they each have their separate plans.
Well, I understand staff says that is it VA that has 3 or 4 plans?
They have regional plans, like 4 regional.
What I'm trying to find out, if they have multiple plans, is perhaps this information could be transmitted to the chairman. I am wondering how they do transparency, how they assure.
Well, I'm not sure at all that they are able to identify transparency.
Well, then I'd ask you to find out. That is to say, I'm very bothered by the fact that such a large percentage of the prescription drug dollar is in fact in another section of the federal government. And I simply want to know if there's something we can learn from them, or if we are reinventing the wheel here, and if so, then that has to be the case. Mr. O'Brien?
Yeah, just Congresswoman Norton, thank you. Again, urged on by this committee, OPM staff has in fact met with DOD and the individuals who run the TRICARE program to try and learn about how their pharmacy program works. It is a much more of a single contract for pharmacy benefits that they run nationwide with separate regional subcontracts. Again, we are actively studying it, and we have had some very good feedback from the TRICARE folks, and it is a very interesting model that we are learning a lot more about.
And you think that some of that model may be transferable to some of what you're trying to do today?
Back to, we are actively studying that, as well as the other options that were offered by this committee in its forum in September. We haven't completed our analysis, but we are actively looking at it, and when we have completed, we look forward to working with you more on those issues. But
thank you, Mr. Chairman. It's becoming. I thank you, and I thank you, Mr. Chairman, for the additional time, because it's becoming more and more difficult, given the scarcity of federal dollars, for us to rationalize different treatment of large sections of the federal budget for essentially the same purpose. Thank you, Mr. Chairman.
Thank you. Yielding myself 5 minutes. Mr. O'Brien, part of your testimony is more than a little disappointing, I think. For us, in that previous testimony from OPM has been of a similar vein. At one point, one of the witnesses from OPM said that, and this is a quote, "transparency is overrated," and that's a tough thing for an oversight committee to hear. We are intensely interested in getting to the bottom of what costs actually are for our healthcare system, and I know that you came out with a very positive carrier letter yesterday, in advance of this hearing, and I sometimes I feel like I'm pulling you folks along towards the road of reform, and I just wish we were working more closely together, trying to get to the same object, and that troubles me somewhat, and I'm concerned that the agency has become captive to the current system and is resistant to change. As you heard Mr. McFarland say, the most troubling aspect of the current FEHBP program is the utter lack of transparency, how it is so opaque and so complex. We are not mapping the genome here. We are selling pharmaceuticals to federal employees. In my other capacity on the Financial Services Committee, I'm dealing with complex derivatives, currency default swaps, credit default swaps, financial engineering that is increasingly and incredibly complex. It pales in comparison to what we got going on here in selling pharmaceuticals to federal employees. That's all we're doing here. And we've got this construct that is just, it's just mind-boggling and mind-numbing. And I think that's exactly the way it was, that's why it was constructed the way it is to resist change. It resists the threat of being understood by its complexity. And we're trying to drill down and straighten this up, and we need your help. We really do. This current system, we just got to blow it up and get rid of it and get on to something else, because this is not working for the American taxpayer. I think the estimate that Ms. Weaver has put out there of several hundred millions of dollars in savings that's probably conservative, what I see here. I think it's probably closer to $1 billion what we can save. In light of the difference in formularies that we've pointed out here this morning, what we're paying. We have 8 million participants, and we don't use that collective clout, that buying power at all in our systems, and we allow these PBMs to really abuse what I think is is honorable service by our federal employees. We're just letting them take advantage of us, and we cannot do that anymore. Our budget will not allow it. So we got to find some savings, and if we're looking for waste, fraud, and abuse, the FEHBP is a target-rich environment because of the arrangements that we've got going on here. This stinks. If I was a hound dog, I'd be pointing right here. Here's where some savings are. Here is where some waste, fraud, and abuse is going on, and I know it. And we're trying to dig down and get at it. And, we could save the taxpayer a ton of money. We could bring a more competitive model and better serve. Look, we have wonderful federal employees. I'm an advocate for federal employees. They do wonderful work. They provide a valuable public service. And we cannot let this go on. This is just unacceptable. We can't do this anymore. So I'm really looking for your help. And I know we got a new director over there, Mr. Berry, who's on the right. He's part of the solution. He's not part of the problem. He's part of the solution. But we got some inertia over there, inertia at best, and then resistance at worst. And we've got to get at it. Since I'm the chairman and no other witnesses, I'm going to extend myself another 5 minutes. Now, let me ask you, Mr. Boehm, you've been terrific on this, and you have a unique perspective. In terms of transparency, you addressed this in part in your original testimony about the fear that, the concern that's been raised by the PBMs that if people know what they're paying for, then prices will go up and it'll destroy competition. But can you talk a bit more about your own experience and also about some of the protections in the bill so that this is not publicly available information that would undermine their competitive advantage?
The argument, as I understand it,
Sorry.
The argument, that, as I understand it, they put forth is that if the information is publicly available, that the competitors, the manufacturers, and the other chains would actually increase their prices because they'd have more information available. It's a difficult argument to debate because it's not publicly available now. In many other industries, I think we've seen transparency lowers costs, not raise it. But rather than debate that particular topic, I think the most important thing is you have provisions in your bill that make it only available for OPM's use. It's not posted on websites, so the manufacturers can't see what the deals are. So I don't think there's any risk in the way you've constructed your confidentiality that it would be publicly available information. And then I'd question, even if it was publicly available, whether that really would increase cost, because again, I think you can go through a number of retail markets. You can look at computers on the internet. You can look at cars as more transparent pricing information has been made available. Costs generally go down in those environments. But rather than debate the economic principle, I think you can just protect against the disclosure of the information.
Okay. Mr. Beck, you mentioned that your experience in Texas, I wrote down $260 million in 4 years. What's the size of your we have 8 million participants. What's the size of the market there for the...
Mr. Chairman, I'm not real sure. I know it's extremely large. And I think that estimate is low. And I agree with you. I think that the estimate is a little short at $500 million. I think it's over $1 billion.
Yeah.
One thing I wanted to mention, back in 2002, there was a lawsuit brought by the federal FEHBP and I believe the mail carriers. I was reviewing it this morning against Advanced PCS, which is...
Was that mail handlers?
Mail handlers, yes, sir.
Yeah, okay.
Advanced PCS, which is now no longer, it was bought by CVS Caremark. And out of that was a $179 million settlement. In addition to that, there were provisions in the settlement that was a 5-year requirement for transparency standards to be followed. So basically, and that is now expired. So basically, your legislation just extends that federal lawsuit settlement and puts it in legislation that has to do with all PBM contracts.
Yeah. Thank you. I would like to, Ms. Weaver, I think you mentioned some of this in your testimony about drug switching and the abuses. You laid out that very cogent analysis between what folks were paying for that formulary, the $9.99 comparison. Can you drill down that a little bit and elaborate on that analysis that you came up with?
Absolutely. So essentially what we did is we took CVS's generic discount program, which is a list of over 300 drugs that they offer for $9.99. And it's, as everybody said today, it's very hard to figure out what drugs cost, right? So you need a baseline to figure out if you're getting a good deal. So one of the reasons we decided to look at this is a baseline. It's the walk-up price. You pay $10 to join this program, and anybody can get access to 300 plus generic drugs for $9.99. So what we wanted to do was look at, Blue Cross Blue Shield's FEP program. It's the largest plan within the FEHBP. We can compare the prices that the government and those federal employees are paying for every single one of we tested every drug on that list. And what we found, as I mentioned, was that 85% of the drugs on the list cost the federal government or federal employees, and or sometimes both, it depends on the cost structures, more than that $9.99 price. So there's a little bit
So the people with insurance are paying more than the people without insurance.
Exactly.
Yeah.
For 85% of the drugs on the list.
How wacky is that?
It's pretty wacky.
Yeah, unbelievable. Unbelievable. Yeah, I cannot.
And we've heard from federal employees that actually don't use their insurance when they go into a retail store because they know that they can get a better deal. And that's pretty absurd as well, because those people are paying premiums that are supposed to give them prescription drug coverage.
Right.
So
they're paying premiums, and the American taxpayer is paying 72% of that plan, in addition to what the user is paying. So that's what got me absolutely furious over what's going on here. Mr. McFarland, I appreciate your work on this. This has been tough, and you've expressed at earlier hearings your frustration in being able to determine what we're getting for our money, and whether there's an advantage here being had by the federal employee health benefit plan and its 8 million participants in our arrangement with these PBMs. Is there anything that's not in the bill that you think might help your position in terms of understanding what's going on behind the scenes and the real costs between all these relationships, the commissions, the rebates, and that whole relationship between manufacturers and PBMs, and then pharmacies as well?
No, Mr. Chairman, I don't think that there's anything particular that should be additionally placed in the bill. I think it's very complete as it is. That doesn't mean that there might not be some, after further deliberation, some more thinking about add-ons. But at this point, I wouldn't say anything specific. What we're dealing with, I think, your bill clearly covers. Clearly. If I can, let me make a point on something that was presented to me earlier today when we were discussing, as we have been for a few weeks, preparing for the testimony today. This is just a little excerpt from the audit staff, what they noticed. After the large provider agreement was brought into effect, I think in 2005, and that simply meant to us that we were able then to get into those PBM contracts, but as it turned out, it was only in a compliance mode. We still could not get to where we needed to be with that large provider requirement. And my understanding of the large provider requirement agreement was simply whoever ends up paying at least 5%, then they would be considered a large provider. And of course, the prescription drugs, 25 or more percent. So that was an easy identification there. But here's what was given to me. This is from the audit staff. We have noticed a distinct shift in how the PBMs have contracted with FEHBP carriers. What we saw as pass-through pricing initially, with administrative fees and rebates, did a complete 180 degrees. After the large provider agreement, the contracts became based on a percentage off of the average wholesale price for the drugs, with no administrative fees charged and the PBM keeping most, if not all, of the rebates. Because the drugs are priced off a percentage of AWP, our audits consisted of verifying the price charged to the FEHBP. However, we could not compare that price to the actual price paid by the PBM.
Right.
So it was just,
well, they went. Yeah, I understand what they're doing there. The average wholesale price is a moving target. It's different. It means something different to everybody. So you don't have a solid benchmark there by which you can make that determination. What we're actually looking for here is the actual price. Yes. How much the actual cost is and how much we're being charged, and that's all we want to know. We're not, we just want a fair deal. That's all, and one that we can understand on behalf of the people that we represent. And we can't get there with the way this thing's working right now.
Well, we presently receive confidential proprietary information from the PBMs as a database on prescription claims. And we protect that with our heart and soul.
Yeah.
We make sure that is as safe as possible in our particular environs. But then on the other hand, they are saying, but you don't need to see our financial records. but we can also we can give you the personal identification information of our claims people. So it's, you know, saying one thing and doing another.
That's right. That's exactly right. You know, some of the information that's being sold out there and marketed is quite detailed, so it's counterintuitive that they can't give it to you in a form that you can use. All right. I think you people have suffered enough, and I want to thank you. On behalf of the committee, we got a lot going on here today. As you know, there's a few major hearings going on here. I want to thank you for coming before this committee and helping us with our work. I would like the opportunity to continue to work with you. And look, I am not saying that our legislation is perfect, not by any means. That's why we're having this hearing, and that's why we're trying to get input from you. And I think actually you've all been helpful in making this legislation better, and we appreciate your testimony and your help with this. And we're going to allow members who may have had questions to offer you inquiries that you'll, if you're willing, would have to have you respond in writing within 5 days if members so choose. But other than that, I want to thank you for your attendance today, and you're free to go. Thank you. And can we ask our second panel to come up? Third panel, excuse me.
Well, I'm here on behalf of U.S. PERG. I think one of our coalition allies, Mr. David Balto, had originally going to testify. Larry McNeely, pleasure to meet you.
Jack helps.
Yeah.
Welcome. Good afternoon. I'm sorry if we have delayed you with the length of the previous panels. I do appreciate your attendance here. It is the custom of this committee to swear all witnesses who are to offer testimony, so could I please ask you all to rise and raise your right hand. You solemnly swear that the testimony you're about to give to the subcommittee is the truth, the whole truth, and nothing but the truth?
Yes, I do.
Let the record indicate that all of the witnesses each has answered in the affirmative. As with the previous panel, we'll offer a brief introduction before we ask witnesses to offer testimony. Mr. Daniel Adcock is currently Legislative Director of the National Active and Retired Federal Employees Association. Before going To that association, Mr. Adcock worked for the House Committee on Education and Labor's Subcommittee on Employment Opportunities and his Subcommittee on Human Resources, and was an executive assistant to the Assistant Secretary for Aging, Jeanette Takamura. Dr. Jacqueline Simon is the Public Policy Director for the American Federation of Government Employees, also known as AFGE. AFGE watches over the rights of some 600,000 federal and D.C. government employees. An economist by training, Ms. Simon has worked to protect the interests of federal employees at AFGE for over 20 years. Ms. Colleen Kelly is the president of the National Treasury Employees Union, the nation's largest independent federal sector union representing employees in 31 different government agencies. President Kelly, a former IRS revenue agent, was first elected to the union's top post in 1999. I do want to add my condolences and that of the committee. We understand, Ms. Kelly, the incident last week where your colleagues' offices were attacked in Austin, Texas. I am aware that that your organization suffered a loss. Vernon Hunter, Social Security Administration manager, who was killed in that attack in Austin. So our prayers are with your members, and especially the Hunter family. I understand they had 6 kids, and I know that Mr. Hunter's wife also is an IRS employee as well, so makes it even more difficult, but we do offer our condolences in that respect, and we appreciate the fact that you were down there helping with those employees, and I know we had quite a few injured as well. Mr. John E. Calfee is a resident scholar at the American Enterprise Institute for Public Policy Research, who studies the pharmaceutical industry and the Food and Drug Administration. He previously worked at the Federal Trade Commission, Bureau of Economics, and has also taught marketing and consumer behavior at the business schools of the University of Maryland, at College Park, and Boston University. Mr. Larry McNeely is a U.S. Public Interest Research Group's healthcare advocate, advocating the organization's federal-level advocacy, communication, and organizing on health care reform. Mr. McNeely lobbies Congress for legislation that will tame rising health care costs and offer consumers better choices in the health care marketplace. As was indicated earlier, the little box there in front of you will be green when you should be speaking, yellow when you should think about wrapping up, and red when you should stop offering testimony. Mr. Daniel Adcock, you are now recognized for 5 minutes.
Chairman Lynch, I appreciate the opportunity to testify. I'm Daniel Adcock, Legislative Director of the National Active and Retired Federal Employees Association. 2 important issues to our membership are access to the latest in pharmaceuticology technology and ways to manage the costs associated with life-saving and life-enhancing drugs. Under the expected technological revolution in medicines, diseases that were once fatal or debilitating will become chronic and manageable. Ailments once requiring surgeries or stays in hospitals or nursing homes will be treated by pharmacology at home. Due to advances in human genomics, our medicines will now be tailored to our own DNA. This means drugs will be more likely to treat our ailments while mitigating side effects and drug interactions. Many women suffering from breast cancer have been prescribed tamoxifen, have already been the beneficiary of this new age of medicine. And this is only the beginning. The medicine bottle cap may be able to tell your cell phone or home computer where you mislaid the bottle or alert you if a child or other unauthorized person has opened it. Your doctor's office or a family member may be able to know if the bottle was open and your daily dose removed. Then there's the pill itself. Embedded in the very tablet is likely to be a computer chip that reminds you or someone else that you took the medicine in the correct dosage and whether it was metabolized correctly. The role the PBM will play in this evolutionary change will only become more critical in providing access to cutting-edge drugs while containing costs. Transparency and oversight will become even more important. We can accept the cost of advanced drugs as long as we can be assured that they are safe and effective and that the process of drug pricing such drugs is fair. That is why NARF is particularly interested in guaranteeing that the savings achieved by PBMs are passed on to enrollees. We are pleased that H.R. 4489 tackles this issue. We are heartened to see that the President's budget emphasizes and continues the responsibility of OPM's Inspector General in auditing prescription drug benefits and the role of PBMs. Hopefully, this will improve the contract negotiation process, hold costs in check, and ensure against fraudulent claims. For the 2010 FEHBP contract year, OPM has now requested more information from carriers as they contract with PBMs for their services. Let us hope this brings further information to OPM and the beneficiaries. Drug pricing is very complex, with the processes that involve the drug formulary and the choices between generics and brand names, plus the costs associated with disease management and patient information. Although drug formularies can help to contain costs, they can also prevent patients from getting the most efficacious medication. For that reason, we are glad that H.R. 4489 gives physicians the final say on which drugs should be dispensed. Still, OPM is not alone in seeking greater transparency. In fact, human resource professionals outside government are developing transparency standards to ensure that PBMs are sharing manufacturer rebates and negotiating the lowest possible cost of specific drugs. This experience could be helpful to OPM. It appears that some of what has been proposed in H.R. 4489 could be implemented under OPM's regulatory authority. For that reason, OPM could get a jump start on enhancing its oversight of PBMs before H.R. 4488 becomes law and codifies the additional authority that would be provided to the agency. Still, we strongly believe that nothing should be left to chance regarding OPM's ability to access PBM information. For that reason, we believe that transparency should ultimately be legislated. As we continue to work with you on this important legislation, NARF would be interested in information from OPM or the Congressional Budget Office on cost savings, formulary development, and administrative costs that might arise from such regulatory or legislative initiatives. Beyond H.R. 4489, we believe FEHBP plans should buy prescription drugs from enrollees at the discount mandated by the Federal Supply Schedule. However, if the FSS were to be used, FEHBP plans must have the option of buying off-formulary medications. NARF would also support your proposal to designate FEHBP PBMs as subcontractors under federal acquisition rules. We commend you for your interest in fair prescription drug pricing in the FEHBP, and we look forward to working with you on this issue. Your prescription for the future of our health insurance program is a welcome addition, and we thank you for your effort.
Thank you, Mr. Adcock. Dr. Simon, you're now recognized for 5 minutes.
Chairman Lynch, thank you very much for the opportunity to testify today. Focusing on the operations of pharmacy benefit managers is an excellent place to begin improving the affordability of FEHBP, since the costs they impose are a big cause of the program's continuously rising prices and its lack of affordability for so many of our members. Although AFGE strongly supports H.R. 4489, I'd like to focus my statement today on one provision of the bill that, if altered slightly, could have a significant impact on the cost of FEHBP. Specifically, that provision involves limiting the prices that PBMs can charge to FEHBP carriers. The maximum price for prescription drugs in the bill, it says, would be an amount that's equal to the average manufacturer price for the drug, as disclosed by the manufacturer. However, given the size of FEHBP, AFGE believes that the government and plan participants should receive the full advantages of their purchasing power, and that means a better bargain than average prices. That PBMs may be currently charging FEHBP higher than average prices for drugs is unconscionable. AFGE supports a much stronger pricing standard than that which is set forth in the proposed legislation. We would recommend limiting these prices to the amounts provided for in the prescription drug price schedules used by the Department of Veterans Affairs, DVA. Alternatively, the legislation could limit the maximum reimbursement to a, quote, most favored customer pricing model. Technically, the General Services Administration, GSA, delegates authority to negotiate these prices and has done so for DVA. There's no reason why the same authority could not be extended to OPM with regard to FEHBP, but it would be far more efficient for OPM to simply use the VA prescription drug pricing schedule. We've heard the arguments from the organized pharmaceutical industry that extending statutory pricing schedules to additional federal health care programs will result in higher prices for all government purchasers. They seem confident that no one can or will expect pharmaceutical companies to accept lower aggregate profits. AFGE believes that we should all call their bluff. Even if the drug companies do succeed in raising prices for all federal purchasers as the price of selling to all federal programs at a uniform price, it's likely that the government will still save money. FEHBP is large enough that a substantial decrease in its drug prices could offset retaliatory price increases that the drug companies might try to impose. A final concern involves pricing transparency, which has been discussed a lot here today. AFGE believes that in order for the legislation to have meaningful price transparency, the requirements of TINA, the Truth in Negotiations Act, should be applied to the program. Both FEHBP carriers and PBMs utilized by the carriers should be required to make available to the government agencies all cost and pricing data related to the purchase or reimbursement of prescription drugs by these entities. They provide it to other federal agencies and other contracting situations, and there's no reason they shouldn't be required to provide that same data in this context. In addition, AFGE believes that the application of cost accounting standards should specifically be applied to the FEHB carriers and PBMs in order to ensure that accounting for the pricing and reimbursement of prescription drug costs is performed in a uniform and consistent manner. The President's fiscal year 2011 budget proposal indicates that OPM's Office of the Inspector General intends to develop its ability to audit PBMs. The budget cites OPM estimates that prescription drugs make up 26% of FEHBP's costs and will total $11 billion next year. The benefits of more thorough auditing should be substantial. Requiring FEHBP carriers and the PBMs to adhere to the cost accounting standards will give the OPM IG the tools it needs to carry out these audits in a way most advantageous to taxpayers and enrollees. This concludes my testimony, and I'd be happy to answer any questions you may have.
Thank you, Dr. Simon. President Kelly, you're now recognized for 5 minutes.
Thank you very much, Chairman Lynch. I am here on behalf of NTEU members who participate in FEHBP and diligently pay their ever-rising premiums for health insurance only to receive reduced coverage and higher copays and coinsurance costs for their prescription drugs. We were very pleased to participate in the Subcommittee's drug pricing forum last September that aptly highlighted the incongruity in FEHB, a program with one of the largest enrollee pools of 8 million people, as we've heard, yet one that gets the worst prescription drug prices in government. H.R. 4489 takes a giant step forward in addressing the problems of why OPM has been unable thus far to better leverage what should be a significant advantage. According to OPM's Inspector General, as we've heard, the cost structures of the pharmacy benefit managers in FEHB are utterly non-transparent. Because the contracts cannot be audited properly under the current system, OPM does not have all of the information it needs to make any substantive improvements. Common sense dictates that U.S. taxpayers, and especially FEHBP enrollees, who saw their premiums rise roughly by 9% this year, or 15% if they were a single enrollee in the popular Blue Cross Blue Shield Standard Plan, deserve better than that. H.R. 4489 says if a PBM and carrier want to participate in FEHBP, certain conditions need to be met. NTEU supports this approach in the accompanying goals of transparency and accountability. A tenet of transparency and accountability is increased disclosure. Just as the administration calls for greater disclosure in government through information and data sharing by federal agencies and individuals, it is only fitting for these billion-dollar private companies who make a profit from government business to become more transparent through disclosing relevant information as well. If PBMs want to participate in FEHBP, they should be held accountable, as 4489 proposes to do. Therefore, NTU supports Section 2H of the bill, which would allow OPM to access information on arrangements the PBMs have with manufacturers and pharmacies. The range of information that OPM would have available through these kinds of disclosures would include corporate-wide rebate reports, rebate allocation methodology, benchmark pricing, and various fees at different stages. These will all put the agency in a position to better do its job. We are not advocating public dissemination of proprietary information, but we are advocating disclosure to OPM as needed so it can monitor the federal program. We also support the bill's approach to prescription drug rebates in Section 2C and believe the language could be clarified even further to improve FEHBP. PBMs were originally intended to handle administrative functions associated with drug claims. Now PBMs negotiate for discounted drug rates and receive hidden payments and rebates from manufacturers, as well as other fees and payments from carriers. Under Section 2C, with 99% of rebates and fees being returned to the insurance carriers, NTU would also recommend additional clarifying language to ensure that the funds recaptured will be dedicated to the FEHBP program and be used to keep enrollee costs down, as we understand DoD's TRICARE health plan does. Under TRICARE, rebates are put back into the insurance program and the PBM receives an administrative fee for services. NTU also believes the consumer protections in 4489 are a very positive step. The ones on drug switching and on selling claims data and on timely explanation of benefits. The PBM does not know what is best for patients, so the drug switching issue should go away, and the only way that should be able to occur is with appropriate medical input. We support an end to that practice. Now, on selling claims, while we question the practice of selling FEHBP claims data at all, at a minimum, OPM's concurrence should be a part of that process. And on EOBs, FEHBP enrollees will benefit from this added disclosure of prescription drug costs, enhancing their ability to choose the best plans for their needs. Finally, NTU would support adding language to 4489 to provide a pilot test of statutory pricing. We have long believed that OPM should investigate the possibility of buying prescription drugs off of the federal supply schedule, as we've heard that the VA and Defense do. Their drug prices are substantially lower than FEHBP. 10 years ago, I testified before Congress in favor of a small pilot that OPM had approved for the SAMBA health care plan to allow access to the federal supply schedule for its mail-order drug program. SAMBA argued it could save 3% annually in enrollees' premium shares by directly buying from the government. Overall savings would have been $2.4 million annually, and that was back in $2,000. Despite OPM's approval, the pharmaceutical industry, whose profits 12 years ago were estimated at $26 billion, pulled out, and they refused to participate in the plan. NTU would support a demonstration project to examine hard numbers associated with the direct purchase of drugs through the FSS, and we would support adding a provision to H.R. 4489 to make that happen. I believe this approach offers a real opportunity for cost savings. I thank you for the opportunity to testify today, and we'll be glad to answer any questions.
Thank you. Mr. Calfee, you now recognize for 5 minutes.
Thank you, Mr. Chairman. It's a privilege to speak at these hearings. The views I present are my own, not those of any organization, including the American Enterprise Institute, which does not take institutional positions on specific legislation, litigation, or regulatory proceedings. H.R. 4489 focuses on the role of pharmacy benefit managers, or PBMs, as we have heard, in federal employees' health benefit plans. On the whole, the provisions of 4489 would do far more harm than good for consumers and patients and would increase health care costs. This bill is based on the assumption that competition does not work well in the PBM market. The facts belie this premise. Competition is vigorous and multifaceted. Standalone PBMs compete among themselves and also compete with retail pharmacies, large health insurance plans, large employers, and even pharmaceutical manufacturers themselves. In this highly competitive environment, employers and insurance plans have negotiated a rich variety of PBM contracts that reflect the specific preferences of the contracting parties. Another indicator of vigorous competition is the fact that a detailed investigation by the FTC, the Federal Trade Commission, found very little evidence of favoritism or self-dealing on the parts of PBMs, regardless of who owned the PBMs. 4489 would force nearly complete transparency in the financial arrangements between PBMs and their partners. This would be difficult to achieve. But if the legislation does bring this kind of transparency, it would undermine the incentives of PBMs to negotiate discounts from pharmaceutical manufacturers. This has been recognized by the FTC staff and by other economists. 4489 would also require PBMs to pass on virtually all the savings they realize from aggressive cost cutting. This would undermine the incentives to cut costs in the first place. This cost cutting comes primarily from negotiating rebates from pharmaceutical manufacturers. Undermining these incentives would raise costs. This adverse consequence of regulation has also been recognized by FTC economists and by others. 4489 would also establish price controls, which rarely, if ever, does good in competitive markets. The prohibition on negotiating a spread between payments to manufacturers and to pharmacies would discourage PBMs from seeking to reduce drug prices and costs. Giving OPM the power to set ceilings on pharmacy dispensing fees would require OPM to uncover the true costs and benefits of dispensing for pharmacies. This is not easily done, and it could easily disrupt access or even increase costs. 4489 would prohibit health plans from reimbursing more than what is called the average manufacturer price, or APM, and OPM would be granted new oversight powers on drug pricing. There is no reason to think this would reduce prices directly, because manufacturers can adjust prices outside of the FEHB system. But this measure could easily set the stage for direct price controls over pharmaceuticals, as we have already heard. This would have extremely adverse consequences for researching and developing new drugs and new uses for approved drugs. 4489 would also impose restrictions on who can own a PBM. This would tend to reduce competition. In addition, these restrictions would deprive the marketplace of the benefits of vertical integration. For example, ownership restrictions would sometimes add extra steps in the pricing of drugs as they proceed through various channels from manufacturers to patients. 4489 would also expand regulation of drug formularies. Little, if any, evidence indicates that PBMs harm patients through the design and operation of formularies. New restrictions are more likely to raise costs than to improve health. Finally, 4489 would grant OPM the power to prevent PBMs from selling information on drug utilization and sales. This would be unfortunate. This kind of information can play an important role in the larger task of improving pharmaceutical targeting and use. And again, there is little, if any, evidence of consumer harm from these practices. For all these reasons, I respectively urge this committee to reconsider 4489. There is no reason to prevent employers, health plans, and pharmacies from negotiating whatever arrangements they wish with PBMs. Thank you, Mr. Chairman.
Mr. McNeely, you are now recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Chairman, members of the committee, I very much appreciate the opportunity to come before you today and testify about this bill and its effort to control drugs and the cost of drugs in the Federal Employee Health Benefits Program. As I said, my name is Larry McNeely. I'm the healthcare advocate with the United States Public Interest Research Group. U.S. PERG, as we call it, is a national federation of state-based consumer advocacy organizations. We have a 35-year history of standing up for consumers, and we're convinced that both strong competition and strong consumer protection are essential to the functioning of any market. Unfortunately, the pathway for pharmaceutical delivery in this country, the market for pharmaceutical benefit managers, PBMs, lacks that adequate competition, and it lacks the consumer protections that are required. And that's why the reforms envisioned in H.R. 4489 are so necessary to help bring down costs. And in explaining the benefits of transparency, I think a lot has been said in this panel and the previous panels. I just want to refer to the comments of Assistant Attorney General for Antitrust, Christine Varney, who highlighted its importance when she said, "I am a firm believer in what Justice Brandeis said in another context. Sunlight is said to be the best of disinfectants, electric light the most efficient policeman. Markets work better, and attempted harms to consumers are more likely to be thwarted when there is increased transparency to consumers and government about what's going on in an industry." I could not say it better. In my written testimony, I go into more detail, but just to outline a couple of the essential points. If the three essential elements of any competitive marketplace are choice, transparency, and a lack of conflict of interest, the PBM market actually lacks each one of those three. It's highly concentrated. We actually have some evidence, which I detail in here, of legal action to stop deceptive and fraudulent practices, and we continue to see these practices of drug switching and self-dealing, which are not only unfair to federal employees in this particular context, but are spread more broadly across the healthcare market, and we really think needs addressing in other legislation. We believe enacting H.R. 4489 will lead to significant cost savings for taxpayers. The proposed legislation will actually lead to a reduction in pharmaceutical costs by requiring the pass-through of rebates and prohibiting the practices of drug switching and spread pricing. And it will protect employees and taxpayers by preventing conflicts of interest that we've run into in cases like CVS Caremark, where PBM is owned by a retail chain. These assertions are backed up by a growing body of evidence that demonstrates that plan transparency does allow plan sponsors to monitor and curb their prescription drug spending. I detail a number of examples, but in one case in New Jersey, when they switched to a pharmaceutical benefit manager contract that was transparent for 600,000 covered employees, they're now projected to find $558.9 million in savings over 6 years. If we're talking about 8 million federal employees, certainly a substantial amount of resources are available. And just to sum up, I think, our attitude and why we're, I think, so grateful to the sponsors of this legislation for moving it forward is that without the protection afforded in H.R. 4489, it's as if the pharmaceutical benefit management industry is saying to taxpayers, saying to federal employees, give us $10 billion of your money and trust us. The PBM industry as a whole, as we demonstrate in some of the lawsuits that I detail in my testimony, has not earned that trust. And we should make sure, I hope this legislation gets favorable consideration by the committee. Thank you.
Thank you, Mr. McNeely. I now yield myself 5 minutes. I want to thank you all for your testimony. I really appreciate your willingness to come before the committee. Mr. Calfee, I have great respect for the American Enterprise Institute. They have long been advocates of good government, I think. And I'm a little puzzled. I know that you testified previously before the House Energy and Commerce Committee to the effect that that prescription drugs in the Medicaid program should more closely reflect costs. Now, during today's hearing, you have heard both Republican and Democratic members express the frustration that we cannot determine what the costs are of the drugs in the FEHBP program. We have heard from the customers, the users, that they cannot determine what the costs are of the drugs offered in the FEHBP program. We have heard from the Office of Personnel Management, responsible for oversight of the FEHBP program, that they indeed cannot determine what the costs are of the drugs in the FEHBP program. We've heard from the Inspector General of the OPM, who says, and he is principally responsible for the oversight here, that he cannot determine what the costs are in the drugs for the FEHBP program. And we even have an example of a program where 300 drugs are offered to the general public with no insurance, and they are paying less money than insured individuals are paying through their pharmacy benefit managers in the FEHBP program, which is funded on an average 72% by the taxpayer, roughly 28% by premiums paid for by the individual. Why would you support, the principle that Medicaid drugs should be, as closely as possible priced based on cost, and yet your testimony here today seems to be at variance with that, if not directly opposed to it.
You're referring to my own testimony in connection with Medicaid?
Yeah.
I'm trying to remember what I said, but I imagine what I said was that the Medicaid should pay market prices rather than getting a special fixed discount from market prices. But, you know, they should go out in the market.
We were testifying in 2005 before the House Energy Commerce Committee. It says closely reflect costs.
By cost, I was referring to market prices. Certainly, I was not referring to the cost of manufacturing the drugs, because those costs are very, very small compared to any prices. But my understanding, especially from the testimony of Mr. O'Brien earlier today, is that all of these plans are free to reach contracts with PBMs that do provide for disclosure. In fact, I believe that's what Argosy Systems specializes in. And so my understanding is that if a plan wants to have transparency, if they want to have the rebates passed through to them, they can arrange through that. They can arrange for that through contracts. And so I think the issue here is whether or not they have the freedom to either have a contract that does provide for transparency and pass through rebates, or to have a contract that doesn't do that. And what we've heard in the private sector, outside of FEHB, is you get both kinds of contracts. You get contracts with transparency, ones without, et cetera, et cetera. The plans experiment with different ones. Sometimes they save money from when they switch to one approach to another, and sometimes they don't.
But sir, in this case, we are the customer. I am a federal employee. I am an oversight officer on behalf of the federal employees. It's not as if we said we want a contract with no transparency. We're demanding transparency, and we can't get it. Nor can the Office of the Inspector General. We can't get that transparency. Nor can the Office of Personnel Manager. We can't get that. The PBMs and the contracting parties here are saying that it's a matter of proprietary advantage, and they don't want to disclose that. So we have had instances where it's gone to court in the state of Maine example, where I think the heat of that litigation broke the case open for the state of Maine, and it was a great advantage. But absent that urgency and the consent decree that was rendered in that case, that transparency would not be forthcoming. So it's not like, we'd prefer transparency, we would not prefer transparency. We're demanding it, and we cannot get it. That's the truth of the matter here on behalf of everyone that I mentioned, Republican and Democrat, so far.
Again, I know in the private sector outside of FEHB, it's fairly common. It's not the rule, but it's fairly common. It does happen that a plan will have a contract for transparency, such as with Argosy Systems that we heard about earlier. But if you think about negotiating, a PBM negotiating with a drug manufacturer, if it wants to get a discount on a certain drug, and if that manufacturer knows that any discount he provides will instantly be communicated through the plans to other drug manufacturers, and the other manufacturer will probably offer to match that price, then what the manufacturer knows during the negotiating process is there really isn't much to be gained by the manufacturer by providing a discount, because they will end up having to give that discount to everyone. So I think it's economic reasoning does suggest that if you force transparency, you can make these negotiations more difficult, discounting more difficult to obtain. And I think that's fairly close. I wouldn't call it a consensus, but I would say the bulk of economists follow that line of reasoning, including specifically the Federal Trade Commission and also CBO.
I appreciate that, but I think we did hear testimony here today, and in my bill specifically, it's not requiring public dissemination of proprietary interests here. We're talking about you need to tell the Office of the Inspector General for OPM. They already receive proprietary information. They guard that jealously. And in fact, if that information got out, it would hurt their credibility enormously and affect negatively their ability to do their job. So that's why we're suggesting it just be limited disclosure. Let me go on though, Mr. Adcock. I know that you mentioned earlier the number of NARF employees that are included under the FEHBP program. Let me ask you, what's the general assessment in terms of your own employees, your own members, attitudes towards the current FEHBP program, specifically towards OPM's oversight of prescription drug programs within the FEHBP?
Well, I think it's kind of a love-hate relationship. On one hand, I think that they're happy that they have health insurance that's equivalent to what other large employers provide, but I think they hate the fact that they're paying premiums in the double digits for the last several years. With regard to prescription drugs, I mean, I think they understand very clearly that that is one of the huge cost drivers in the program and responsible for huge premium increases. Now, I think that over the years because of the fact that several years ago they were encouraged through cost sharing to start using mail order prescription drugs, and thereby pharmaceutical benefit managers, and they're now accustomed to doing that. I think that where there's concerns that we hear most often is that when we hear examples that individuals that don't have any insurance at all can go into a drugstore and get a better price on a specific type of drug than they can through the insurance, that's troublesome to them. When they hear about that state attorney generals all over the country are involved with legal action against pharmaceutical benefits, that's troublesome. And so, on one hand, I think that when you're talking about the customer service that they have with pharmaceutical benefit managers and arranging for their drugs to be purchased, I think a lot of these PBMs have very good customer service. But when they hear about these stories, they want to know what's going on behind the curtain. And that's why I think for a lot of them, they're very interested in the subject matter of this legislation and transparency.
Dr. Simon, can I ask you the same question with respect to, I know the American Federation of Government Employees has a tremendous amount of employees affected as well. What are the attitudes? I don't know if you're close to that level of feedback, but...
Oh, I am, but I just want to say, especially in light of the oath that we took at the beginning of the panel here, I never finished my dissertation, so I'm not Dr. Simon.
Okay.
But in any case,
right. We won't hold that against you.
But thank you for the presumption. In fact, AFGE is holding its annual legislative conference this week, and during the issues briefing this weekend, I don't think there was any subject that raised people's hackles more than what's been going on in FEHBP. Wow. Part of that is because of the national health care reform bills that would impose a so-called Cadillac tax on their FEHBP plans, and I think today's hearing shows that there's nothing about the benefits that make it a Cadillac. It's the fact that we pay too much. The price is too high, but the benefits aren't necessarily luxurious or comprehensive. And so if that goes forward, they'd get hit again for something that's completely beyond their control. We often, when we testify on FEHBP, note the fact that there are, we don't know the number exactly, but there are at least a couple 100,000, if not more, federal employees who are eligible to participate in FEHBP but don't participate and don't have insurance from another source because they can't afford the premiums that are on average now 30% for the enrollee, and they keep going up. And so many of our members work in veterans hospitals or in prisons and DOD medical facilities where they may be providing these prescription drugs to inmates or patients in the veterans or patients in the DOD hospitals, and they know that the same government that's paying for their health insurance through FEHBP is paying one price if they were prescribed that drug, and a completely different price when they're dispensing it in a VA hospital or a prison or through the Indian Health Service. And they're very, very aware of the fact that FEHBP has not been run in a way that would minimize the cost to taxpayers or enrollees. And as it gets more and more expensive, and each year as a higher and higher percentage of overall premiums is shifted onto the employees, they're livid. They're livid. They're getting a small pay increase, and they're FEHBP premiums are going up, and they're not. They like this legislation.
Okay, thank you, President Kelly. I know you've got a pile of employees that are also affected all over the place, right?
We do, Chairman Lynch, but it does come down to the single issue of the cost of the plan, and because everything points to the fact that these annual increases are so directly tied to the cost of prescriptions. And I would also say that the forum that you held last September, on this issue, for those who did not know about the federal supply schedule and the prices that were being paid so differently at DOD and VA, they know that now, and they have more questions about why that would be allowed to continue to happen and why OPM, the question has always been what OPM will do to better leverage the 8 million enrollees. And of course, like I said, it always comes back to the prescription drugs is the one element that is always pointed to when the annual increases are announced each year.
Well, let me ask you about that then. We had this forum. I guess I had an inclination to try to do the simplest thing, which we have a government purchasing system under the FSS, that federal supply schedule, and it's fairly it's well known. It's well used. It's established, and it's used in general government purchasing, and it's fairly transparent. You put it out there what you're going to charge the government for providing a certain material or service, and it's competitive. And my thought was, rather than this very, very Rube Goldberg type construction that we've got for federal employees' health benefits on the pharmacy side, let's just put it out there like we would for widgets. And you offer your price to the government, and we accept it or reject it. We can consider quality and level of service. Let's just do that. And the PBMs were the loudest critics of that system because it would eliminate them from the whole process, basically. At the same time, now that's a very crude solution to our problem. It simplifies things, but I'll take for granted that widgets are not the same as pharmaceuticals being recommended by a physician for the health care of that individual, and there's some important differences there. However, when you look at the VA system that's out there that works pretty well, they have a fixed formulary, however. So there's a more limited choice, although there are waivers under certain circumstances. How would your members respond to that if there was a fixed formulary? Because that's going to reduce, conceivably, it's going to reduce some level of choice for some of these, exotics or some of these less commonly used pharmaceuticals. It's going to be a limitation on choice. How are they going to balance the likes and dislikes of a system that might have a fixed formulary but a much lower price across the board?
I don't know how they will react to change in general, but any kind of a positive change I think would be received. But one of the things that NTU has recommended is that this be done as a pilot, that it not just be an across the board, because then all of the benefits that we already know exist, such as a transparency,
right.
For those who oppose it, it's already there. It's the obstacles that they're raising have already been overcome with the use of the FSS. So let's try it in a pilot in one or two of the plans in the program, and see exactly what kind of an impact it would have, and if there are other issues that are created that haven't been thought about.
Like I said, there are waivers, or there are ways to, if something's not on the formulary, if you make a showing that this is needed, then there's a way to get around that. But it does put sort of a gatekeeper on the formulary. Mr. McNeely, you had some great testimony earlier on about competitiveness and transparency. Are there items, as you look from U.S. PIRG's standpoint, are there items that should be added to this legislation that we may have forgotten, or that you might think would be helpful?
Yes, and we'd be happy to work with you, but we generally believe that there's some steps that will be taken to strengthen the consumer protections within FEHBP by establishing an ombudsman and some other measures, which I'd be happy to work with the committee in terms of those suggestions.
An ombudsman in what respect? With appeals to which body? The carrier, the pharmacy, the PBM? It's okay. You know that. Yeah. I'm getting a little deep in the weeds here, and I don't want to put you on the spot.
Okay.
Okay.
Thank you.
Are there any other matters that we've overlooked here in terms of trying to? As I said at the outset, this legislation is not etched in stone, and we've heard from both panels, all three panels actually. I think constructive recommendations that we could improve our bill, and we're happy to do that. But are there other items that you think? How about the suggestion that was made by Representative Treat from Maine about importing a standard of fiduciary responsibility on the part of the PBM to act as fiduciary on behalf of the plan, of the insured, the participants? Any thoughts on that?
The imposing a fiduciary duty on the insurance carrier or on the PBM?
PBM.
On the PBM. I guess I don't know enough about what kind of responsibilities that would involve and what the checks would be in terms of the oversight on the employer to ensure that they were actually complying with those fiduciary duties. I mean, obviously, as an employer, you're a fiduciary or should be at least a fiduciary of your health plan on behalf of your employees and retirees. But I'm not sure exactly how that would work with a PBM.
Well, I think what they're trying to get at is this. You're hiring a pharmacy benefit manager to get you the best deal. That PBM goes out there, negotiates a deal for you as your agent. But unbeknownst to you, because of the way the system works right now, they pocket part of the advantage that you paid them, you've already paid them as your agent to go out there and get a good deal. Then they get you a good deal, a great deal maybe, but then they pocket part of the advantage and come back to you and give you some measure less than what you paid them to get you. And so, that sort of gives a little bit of a snapshot on the problem here, right, that these deals are all going on, and you never know what the real cost, as Mr. Weiner testified, you never know what that bottom line cost was. But with a fiduciary responsibility, it would make it clearer that the benefits flow to you, that person, that PBM is out there negotiating for your benefit as your agent, and it would require full disclosure of any advantageous relationship that they engaged in that may be in contravention of your own interest.
I guess my question would be is that if there is such a fiduciary duty, what sanctions would be made against the PBM if they breach that duty?
There's a great deal of case law that's been developed around the responsibility of fiduciary responsibility, and I think that would all be imported. Those standards would be implied, or not implied. They would be applied if we import the fiduciary relationship, with respect to a PBM and the people that you represent. I think. Okay. You know what? I just want to ask you each if you have anything that you'd like to add. We have this is a series of roll calls, so I don't want to. I would rather be able to dismiss the panel and adjourn the hearing than come back. So I think we're probably at that point anyway. You've suffered enough. Ms. Simon?
Oh, well, I just would say very quickly, I think that this idea of imposing fiduciary responsibility on the PBM makes it even more important that we would have the cost and pricing data that would be triggered by application of TINA, the Truth in Negotiations Act. We would find out what prices they were charging to all their customers and what the actual cost of production of these drugs is, and that in many cases when you're buying drugs, it's a sole source contract. And that's what triggers the applicability of TINA, where you find out this data. Again, a proprietary data that would be held by the agency, so it wouldn't be made public, but it would allow the government to enforce this fiduciary standard on the PBM. So either way, we need this data. We need this information.
Okay, great. President Kelly?
I will be looking more at the main experience and at that language, but it just seems to me that that language on fiduciary responsibility would add to the transparency, which is the goal of the legislation, and that would be an enhancement to it.
Yeah, that's my reading as well. Mr. Calfee, please.
Yeah, I would suggest that the most dangerous and counterproductive part of this legislation is the pass-through. If you say to a PBM, we want you to go out and negotiate on a really good discount, negotiating discounts is not a straightforward thing. I mean, if anyone can walk into a pharma firm and said, give me a 20% discount, and they would give it to them, and everyone would get the discount. It's a tricky business. And if you say to the PBM, we want you to go out there and do all this work in negotiating and discounting and figure out these clever things, working with formularies and so on, and then give all the returns to us, you're not going to get any discounts. What it really does is it puts the onus on the plan to negotiate the discount. If they can do that, fine. Sometimes they can, but sometimes they can't.
Okay. Mr. McNeely.
Yes, I just wanted to weigh in on the fiduciary responsibility piece. We'd have to take another look at the main legislation, but I think we're generally inclined to support that direction if that's direction the committee moves with. Yeah.
Great. Thank you. As you notice, we've got several hearings going on at one time, and I'm going to leave the record open in case any of the members have any questions for the members of the panel. I do want to thank you very, very much for your willingness to come before the committee and help us with our work. This is tough stuff. It's very complicated, but I think you're each in a position that's very, it has a unique perspective, and it's very helpful to us in trying to figure out how what the intended and unintended consequences might be. So I want to thank you for your testimony here, and you're free to go. This hearing is now adjourned.
Thank you, Mr. Chairman, for holding the hearing. Mr. Gingrich, question. Mr. Chairman, and Ms. Lynch, very